The health consequences of climate change are not a prediction to be made. They are a documentation to be acknowledged. The Lancet Countdown on Health and Climate Change, which publishes annual surveillance reports synthesizing data from dozens of research institutions globally, documents with increasing precision what is already happening. Heat-related mortality is accelerating, vector-borne disease geography is shifting, air quality is worsening in regions previously unaffected by certain pollutants, and the mental health consequences of ecological disruption are being measured in populations worldwide. Let's be specific about the mechanisms, because abstraction tends to dilute urgency. Dengue fever, historically confined to tropical latitudes, has established transmission in southern Europe and the southeastern United States as mosquito habitat ranges expand northward with rising temperatures. Malaria vectors are being detected at altitudes previously too cold for their survival. Heat-related organ failure, particularly acute kidney injury and heat stroke, kills thousands annually in events that, attribution science has now demonstrated, would not have occurred without anthropogenic climate change. Wildfire smoke, which carries ultrafine particulate matter capable of penetrating deep into lung tissue and entering the bloodstream, is causing cardiovascular and respiratory mortality in populations hundreds of miles from any fire. The mental health dimensions are less discussed but equally real. Climate grief, the psychological response to the loss of ecological stability, familiar seasons, and environmental predictability, is being documented in clinical populations, particularly among young people. The psychological burden of repeated disaster displacement, of watching the landscape of childhood become unrecognizable, of inhabiting a body that registers extremes as threats, is a clinical reality that psychiatry has barely begun to formally address. Medical systems are, on the whole, still organized around a relatively stable disease ecology that no longer exists. The infectious disease specialist who trained 20 years ago trained in a geography of disease that has already meaningfully changed. The emergency physician planning hospital capacity does not yet have formal frameworks for climate-driven patient surge patterns. Medical schools are beginning to integrate planetary health into curricula, but the integration is recent, uneven, and chronically underfunded relative to the scale of the problem. The call to action here is institutional. Healthcare systems need to conduct climate vulnerability assessments of their own infrastructure, hospitals in coastal flood zones, power-dependent facilities in heat event regions. Clinical training needs to routinely include climate medicine literacy. Epidemiological surveillance systems need climate-informed disease forecasting models. None of this is optional. The greatest public health emergency of this century is not waiting for medicine to decide whether to take it seriously. It is already presenting at the emergency room.